Hello and welcome to Musculoskeletal Cases. My name is Dr. Andrew Craig. The topic for today's lecture will be the nervous system. And so we're going to start by taking a very overarching view of the nervous system. We'll talk about the various categorizations and the different areas of the nervous system within our body. This is a massive, massive, massive topic. And so I'm sort of going to pare it down to more of a clinical and um, pare it down to a view that's more clinical and rehab focused. We will separate it between this week and next week, where we're going to talk about proprioception today and the various structures within the nervous system, compare the central and the peripheral nervous system and the different, the afferent and the efferent pathways, that sort of thing. Then we're gonna end the lecture by talking about proprioception, and then next week will be sort of an extension of this week, and we will talk about the various pain patterns um, that I want you to learn and the various pain pathways as well. Okay. You'll notice with a couple of these lectures this semester, especially this one, there is reference chapters 12 to 14 in your lecture, or sorry, in your textbook. However, a lot of this is content that I've sort of collected myself over the years through different courses that I've taken, and added it here for you to learn about. Okay.
The itinerary for today is going to begin with a little bit of a review of the nervous system. Uh, we're going to look through the different classifications of the nervous system. We're going to look through the different systems that are in place, and I'm going to give you sort of an easy way to remember using a chart. Then we're going to talk and differentiate between the sensory and the motor systems and look at them sort of separately. We will look in depthly at how we perceive pain. And then we will look at proprioception and we will focus on the ABCs of proprioception, which are agility, balance, and coordination. I apologize, they're out of order in this slide. Here is, if you need to learn the nervous system, if you had to learn the nervous system in 5 minutes, this is what I would say for you to understand. If you can understand this breakdown from the nervous system all the way to its component parts, then you sort of have an understanding of which areas of the body and which areas of functioning in the body are controlled by which section or classification of the nervous system. Okay. So very briefly, because we're going to go through this in detail over the next few slides, the most basic classification or division of the nervous system is the central nervous system and the peripheral nervous system. The central nervous system includes the brain, the spinal cord, and that's pretty well it. Okay, so it's everything that's contained within the cranial vault and within the spinal column. The peripheral nervous system is divided into the somatic nervous system and the autonomic nervous system. So if the central nervous system controls the brain and the spinal cord, it is truly your central processing unit of your entire cognitive, motor, sensory, and any sort of nervous system activity. The peripheral nervous system is everything else. So as soon as the nerves emerge from the spinal column, they've gone into the peripheral tissues and they now are known as peripheral nerves or the peripheral nervous system. Again, in order to break down the peripheral nervous system, you have to look at the somatic nervous system versus the autonomic nervous system. We'll first focus on the somatic nervous system. This is responsible for any voluntary control of body movements. It's also responsible for sensation, which is associated with the afferent and the efferent nerves. And so, afferent nerves. Let's take this one step further. So, somatic nervous system is a voluntary nervous system. Afferent nerves are nerves that bring information from the periphery towards the spinal cord. Okay, so these are our sensory nerves. If you touch a surface and it's hot, that's going to activate certain mechanoreceptors in the peripheral nervous system. That's going to send a signal through the somatic nervous system through the peripheral nervous system, and that will link back up to the spinal cord as it enters at a certain spinal level. The efferent or efferent um, nerves or nervous system that involves any sort of motor action. Okay, so these go from the spinal cord towards these basically go from the spinal cord towards the effector muscles. So, for example, if you need to contract your quadricep to extend your knee, what happens is your brain makes that conscious effort in the central nervous system, and then that signal travels through the peripheral nervous system via the somatic nerves as an efferent so that it can elicit a motor response in the muscle. Okay? So that's the voluntary aspect of the peripheral nervous system. If we look at the involuntary aspect of the peripheral nervous system, this is known as the autonomic nervous system. The autonomic nervous system, this involves things like smooth muscle contraction, cardiac muscles, the glands, internal organs, those sorts of things. So this occurs through the sympathetic, the parasympathetic, and the enteric nervous systems. The sympathetic nervous system, this is known sort of as your fight or flight system. This is if you get surprised quickly and you react quickly and you start to sweat, the pupils start to constrict, blood flow starts to be shunted towards the muscles in a fight or flight type of reaction. The parasympathetic nervous system, on the other hand, this is what we call the rest and digest nervous system, or some people might have heard it called the feed and breed nervous system. In most cases, these two systems kind of have opposing effects. Okay, so if the sympathetic nervous system is it's allowing you to focus your eyes on small targets. It sort of increases the hypervigilance. What the parasympathetic nervous system does is it reduces sort of that hypervigilance, and it will shunt more blood towards, let's say, the organs to do vital functions in that sense. Okay, so sympathetic nervous system is the fight or flight. Parasympathetic is the rest and digest. Most of you have likely heard of all of those systems that I just briefly ran over. The enteric nervous system is one that you may not have as much familiarity with. It's a mesh-like system of neurons that lines the intestinal tract. It also lines the mucosa, and it governs all of the gastrointestinal functions. Okay, it is actually capable of acting as its own sort of independent nervous system from the rest of the body, and it does that through these plexuses throughout the entire digestive tract. So it's kind of known as this second brain, and there's a lot of research happening with the enteric nervous system just to understand how does it affect things like, let's say, colitis and diverticulitis and other digestive issues that may present. Okay. So after this lecture, I would encourage you to go back to this slide and see if you can kind of run through the nervous systems and explain sort of the divisions between each. Again, the central nervous system, it includes the brain, the spinal cord, the cranial nerves, and the nerve roots. Once it actually emerges from the spinal cord, what happens is the motor and the sensory nerves will come together from the spinal column, and they will emerge as peripheral nerves, which is kind of the highways to the effector organs. So, for example, if it's a nerve that is supplying the quadricep, a motor nerve that's supplying the quadricep, and it's also responsible for the sensation over the quadricep at the knee, there's a motor nerve that travels from the spine to that area so that it can innervate the muscle and it can actually have that motor, it can actually elicit that motor response. There are a number of ways to classify the central nervous system. And so we're going to just discuss a few definitions just so that we're all sort of on the same page. The term exteroception, this is used to describe any sort of information that is coming in from the external environment. So this can be used to describe basically any sensory information. So you can have visual information, you can have touch sensation, heat, vibration, all those sorts of things. So it's information that you're collecting from the external environment, and it's coming from the environment into the body. Interoception, this is information about any sort of the internal environment. So if you've got, you're having a bit of let's say there's a bolus of food moving through your digestive tract, or you're having a bowel movement, you can feel that and sense that within the body. That would be interoception. Proprioception, which we're going to talk about in depthly, this is the body's ability to understand and transmit position sense. So if you're sitting there looking at your screen, if you close your eyes and you flex your arms to 90 as if you're showing off your muscles, your body can sense the joint position in your elbows so that you know where your body is. Okay. So this is how we understand where we are in space. And without proprioception, we wouldn't have an understanding of how our body is moving relative to the environment around us. So we are going to discuss this concept of proprioception in detail today. The somatosensory system, this is the division of the central nervous system that is concerned with conscious perception of touch, pressure, proprioception, pain, vibration, and temperature. And so we're looking at different types of receptors. We're looking at different types of information that comes into the sensory system. Mechanoreceptors are the receptors they're specialized in responding to mechanical stimulus. So if you use your fingers and you're touching the keyboard, there's a reason why you don't smash your finger all the way through the keyboard. That's because you've got mechanoreceptors that tell you that's enough pressure or that's enough tension. It's also the reason you can sense your cell phone that vibrates in your pocket. You've got mechanoreceptors that are set to actually pick up that type of vibration and allow you to recognize it. Nociception, this is the word for painful stimuli. So nociceptive stimuli, you cut yourself, you start to experience pain. Then you've got thermo and chemoregulators, and this is what's going to sense differences in temperature. It also senses differences in chemical regulation. So you've got a prime example would be the receptors in your carotid artery that can sense the pressure changes and the chemical changes of oxygenation to the brain. Obviously, it's important that we get proper amounts of oxygen to the brain. So there's chemoreceptors that will cause stimulatory behavior in your vascular system to allow for more blood flow to go to that area. So that's thermo and chemoreceptors. I've already explained this in detail in the previous slides, but the afferent division of the peripheral nervous system, that relays sensory information from the external stimuli or from the external environment towards the central nervous system. Okay. So you reach out and you grab a hot potato, okay? The classic game hot potato. Your hand's going to recognize the temperature of it, and so you're going to get a signal that follows the afferent nerves to the spinal cord, which is going to send a signal up to the brain and tell you that this potato is hot. You need to be careful and potentially drop it. The efferent or efferent division, this is what's responsible for affecting change through motor commands. So that hot potato, you grabbed it, you really gripped it hard. It's going to send that afferent signal up to your brain. Your brain's going to go ding, ding, ding. This is a hot potato. We need to drop this. So it's going to send a response via the efferent nervous system, and that's going to send a motor signal to the muscles of the hand to release it. immediately, right? To reduce that noxious stimuli. So if you need a quick way to remember it, afferent is information in or sensory information. Efferent is information out or effector information. Another important thing to understand about the nervous system is the tracks of the spinal cord. Okay. Since afferent information is traveling from the environment upwards to the brain, we call these the ascending pathways because that information is literally traveling along a neuron that is ascending from, let's say, your fingertips. Once it gets from your fingertips to your spinal cord, it must ascend to the brain. So it transmits information upwards. The motor neurons or the efferent nerves, these are signals that are going from your brain to a muscle to tell it to contract. So these must be descending by definition because they go from your brain downwards to the spinal cord. Okay. Now, you've probably heard of white matter and gray matter. White matter is the word that is used to describe the tracks. So if you think about them almost like highways going from the brain out to the periphery, they travel upwards and downwards. So the sensory information travels along the ascending pathways that go upwards, and the descending pathways, those transmit that motor information that's going downwards. So information will travel from the brain to a certain level, let's say T10 or T11 in the spinal cord. And then what happens is it will exit the spinal cord so that it can have an effect on the body around it. So the white matter, that is what we call the track system. So the ascending and descending track system. The gray matter, this is where all of the cell bodies and nucleuses of the neurons live. Okay, so this is an area where you have a lot of interneurons. You've got a lot of transmission of information from neurons, neuron A to neuron B, and you've got a lot of coordination between nerves in the gray matter. You've also got information that can pass from one side of the spinal cord to the other, and this typically happens in the gray matter as well. Typically, information will come in, it will synapse on an interneuron, and it will transmit across to the opposite side. Okay? If you've ever heard that your left side is controlled by the right half of your brain, or vice versa, this is the mechanism under which that happens. Usually the information crosses around the central canal to cross over to the other side of the spinal cord or at the level of the brainstem. And this is sort of just an expansion on what I just explained. Okay, let's talk about skin sensation or afferent sensory input and how do we detect that information? These are two very clinical words or clinical concepts that I want you to understand. You've got something called the dermatomal distribution, and you've got cutaneous innervation or cutaneous distribution. A dermatome, that is the word for an area of skin that is supplied by a single nerve root. Okay. So, for example, the sensory nerve that emerges from the spinal cord at the level of C6 will supply a certain area of the body. And now there are some differences, and everybody is a little bit different. However, these are very, very consistent across populations. So the C6 nerve distribution relates to a certain dermatome. Cutaneous innervation, on the other hand, this is the area of skin that is supplied by a specific nerve bundle. Okay. So, for example, the radial nerve supplies a certain area on the hand, and we're going to look at a couple pictures over the next slide. But the radial nerve isn't just made up of the C6 nerve, or sorry, C6 nerve root. The radial nerve is a collection of C6, C7, C8, those sorts of things. So you need to make sure that you're looking at, is it a dermatome or is it a um, cutaneous innervation that we're looking at? So if we're looking at dermatomes, which is indicated on the left, you'll see that, let's take C6, for example. C6, if we look at the hand, will basically supply the sensation over the thumb. Okay. If we look at the posterior aspect, it's over the thumb and it's over the first finger. Okay. So this information will be relayed back to the spine at the level of C6 in the cervical spine. If we take a look at the cutaneous innervation, okay, what is actually supplying what actually supplies the thumb? The dorsal vagal nerve, which is actually, it's a branch off of the radial nerve. So it is the radial nerve. You can see here on the right, radial superficial nerve, C6 to 8, supplies that little aspect of the thumb. But so I want you to think of, why is this important if you have a client who comes in who has, say, sensation loss in their arm? How can you use this and these two different patterns to identify where the injury is? This is a little bit beyond the scope of this course, but I think you'll find this interesting because this is essentially clinically how chiropractors, physiotherapists, family doctors, how we diagnose, is it a lesion at the cervical spine? So is it a lesion coming from the neck, or is it a lesion that might be pinching that radial nerve as it emerges through the shoulder and then down into the arm? So if it's a dermatomal distribution issue, so let's say the patient presents and they have numbness very specifically in this area here, and it goes all the way up to the elbow, and it just beautifully maps out that C6 nerve distribution. We can assume without any sort of imaging, or we can have a differential diagnosis or a justifiable reason to believe that maybe the lesion is at the neck because it's only impacting this C6 nerve distribution. Okay, so maybe we think it's stenosis, foraminal stenosis, putting pressure on the C6 nerve root, or a disc herniation. Let's say instead that we're just getting a little bit of numbness here in the hand, okay, and we're getting a little bit of numbness into the back of the hand, but it's not emerging up the sort of this brown distribution here, the lateral antebrachial cutaneous nerve. So we're only getting it into the hand. Okay, well then clearly it's not a dermatomal distribution. So maybe just the radial nerves being pinched. So the radial nerve is made up of multiple levels, C6 through to C8. So maybe that nerve is being pinched along its path through the shoulder or through the arm, or as it emerges between the tricep in the back of the arm. Okay, so just some food for thought. If you plan to go into a clinical if you're planning to go into a clinical career afterwards, you'll probably learn that in much more depth. And the same is true for the lower limb. So remember what I said about white matter and gray matter, okay? Gray matter is where we have a lot of those cell bodies, okay? And so a motor signal or a motor nerve originates in the anterior horn. And so the anterior horn, from an anatomical perspective, here's the spinal cord. This is a cross section of the spinal cord. You've got this beautiful little butterfly structure, and this is all of that gray matter, okay? This is the front side of the spinal cord. So that makes this the anterior horn. This would be the posterior horn, okay? So motor nerves originate from that anterior horn, and they exit through the spinal cord via what we call the ventral roots. Okay, this is the ventral root here. So they emerge through the ventral roots. This is where they now become part of the peripheral nervous system. Okay, they've exited the spinal cord. They are now outside of the spinal column, and now we are on the road to sort of the neuromuscular junction. So they travel through the body, and then they get to their end stage, which is that muscle fiber. So then they synapse on the muscle fiber at the neuromuscular junction, and this is where they can start to stimulate muscle contractions. So how do we perceive pain when it comes into the brain? Pain is a very, very, very complex sensation and human experience. Everybody experiences pain a little bit differently. There are full medical fields that deal with pain. There are clinics that deal specifically with pain. And so this is something that is, if it's interesting to you, it's a wide open field of study. And so pain perception comes in many forms. And we're going to talk about a number of different outcome measures that you can use to help to gauge pain. You can see if it's exaggerated pain. You can determine if it's coming from a mechanical perspective or if it's hyperstimulation to the nervous system, all sorts of things. But there are essentially four different areas that I want you to be aware of for pain perception within the cortex. Okay. You've got the primary sensory cortex, or S1. This is believed to be concerned with where and how much pain that you're experiencing. Okay. The other centers, the secondary sensory cortex, the anterior part of the insula, and the cingulate gyrus, these are important for integrating the pain experiences. So these areas is where pain can be combined with, let's say, emotion. It can be combined with memories, previous experiences with pain, your understanding of pain, and it can be a very, very complex situation that is very different for each individual person. The thalamus is essentially this huge structure of gray matter, and it's a relay station for information that comes into the brain that needs to be redirected or integrated with other information before it goes to the sort of edges of the cortex or the cerebral cortex. The thalamus is what we call the central switching station of the brain, and it's essentially just one huge nuclei that's concerned with pain. So it takes in information from the spinal cord. It takes in information from the hippocampus. It takes in information from the vestibular system, the visual system, and it moderates pain. Okay, so it receives projections from multiple ascending pathways, and it's this three-dimensional structure that's really important for modulating our pain experience. There are ways of looking at the thalamus, dividing it up into different areas. So the lateral nuclei, the medial nuclei, these deal with different classifications of pain, but that's far beyond this course. What I want you to know is the primary role of the thalamus is kind of as this central switching station. It modulates pain, it integrates a number of complex signals so that your body can understand and deal with that signal in a reasonable and logical manner. Okay, so now we're going to discuss the sympathetic nervous system, the parasympathetic nervous system, and the enteric system. Remember what I mentioned before. The sympathetic nervous system is what we call the fight or flight response. These nerves emerge from the spine through what we call the thoracolumbar outflow, which goes from the level of T1 down to L2. Okay, so sympathetic nervous system nerves don't emerge in the cervical spine or in the lower lumbar spine. Okay. You've got what's called a sympathetic chain ganglia, which runs along the side of the spinal column. So as soon as sympathetic nerves emerge from the spinal column, they either synapse or their cell bodies are located within that chain ganglia. Okay. Now, a lot of the sympathetic nervous system responsibilities are sort of towards organs, It's towards increasing it will increase sort of the heart rate, uh, respiratory respiratory rate might increase as well. And so the nerves go basically to the sympathetic chain ganglia, and then they will go to the effector organ from there. Contrary, or in contrast, actually, to the sympathetic nervous system, the parasympathetic nervous system follows what we call the craniosacral outflow. So if we look at where these neurons emerge from, we see that they come from the brain or the upper cervical spine, and they emerge from the sacrum. So if we compare that to the sympathetic nervous system, remember that's the thoracolumbar outflow. There's no overlap between these two systems on how they emerge from the central nervous system. The parasympathetic system supplies digestive organs. It also affects the heart, the lungs, the liver, gallbladder, kidneys, you name it. But the ganglions here, there is no chain ganglion, so they don't. There's no there's no ganglia that's right beside the spinal cord or the spinal column. They actually are closer to the effector organ. So, for example, you've got the ciliary ganglion, which is actually in the face and is responsible for the eyes. That exists within the face, so it's not extremely close to the it's not extremely close to the spine. Let's move on to discuss proprioception. And this happy gentleman is showing us how you can sort of stress the balance system and really see how your proprioceptive system responds. Proprioception, simply stated, is the body's ability to know where you are in space. Okay? It uses sensors that are located within the joints, the skin, the tendons, the muscles, to tell you the joint position, the length of the muscles, and to make sort of a mind map of your body's position within space. It allows you to respond to the environment around you. It allows you to respond to small perturbations and to make minor postural adjustments to allow for postural control. Information that's taken from proprioceptors can be used to allow you to understand what's the position of your joints, how fast are they moving, are they under too much load, have they exceeded their range of motion limits, these sorts of things. So proprioception is very important, and it's also known as kinesthesia or kinesthetic awareness. Do you know where you are in space? Agility, balance, and coordination combined together, these are what enable people to move accurately, quickly, and efficiently. So proprioception, the ABCs of proprioception are agility, balance, and coordination. Without proprioception, you would have no idea where your limbs are in space and you would be very uncoordinated. Okay, so just remember that proprioception gives you information about joint pressure, muscle tension, and changes in the body and joint position in space. And we're going to talk about a couple of the different sensors that you should understand in order to get a sense of how proprioception works. Table 6.1 here, this is taken from your textbook, and it's a summary chart that describes the different type of mechanoreceptors within the body. I want you to understand the basics of these different mechanoreceptors, explain which ones contribute to proprioception, also explain which ones might be good for sensing, say, differences in pressure changes or pain, or I want you to know the function of these, okay? You don't need to know where they exist exactly within the body, with the exception of a couple, but we're going to go through a number of these mechanoreceptors over the next few slides. As a quick summary, a quick 1 minute summary, Pacinian corpuscles, these are responsible for measuring strong pressure and vibration. Okay, so they're located deep in the dermis. You can also find them in the joint capsules and ligaments. The Meissner's corpuscles, these also will respond to vibration and very light touch. So if you are doing a full neurological exam, you need to measure all of these sorts of things. You need to measure vibration, sensitivity to temperature differences, so hot and cold. You need to measure pain sensation and pressure and vibration. The muscle spindles, these exist within the muscle. You can see one on the right here. And they are sort of nerve fibers that go into the muscle and they tell you about the muscle stretch. And they're very important for preventing any sort of tearing in the muscles. The same is true for the Golgi tendon organs, except for these are located mostly in the musculotendinous junction and within the tendon. So if your tendons are under extreme load, the Golgi tendon organs are responsible for telling your body or indicating that danger is imminent, and they will allow for either co-contraction of other muscles, or you may just release the weights and have to prevent yourself from tearing a muscle. Okay. So touch is actually regulated by the Merkel's discs or the nerve endings and the Meissner's corpuscles. Okay. These are what we call type 1 cutaneous mechanoreceptors. And so they're slow to react. If we look at the picture on the right, you'll see the free nerve endings are very, very close to the surface. Okay. Free nerve endings, these are the free nerve endings and Merkel's discs. These are very close to the surface. So if you've ever scraped, let's say your hand, if you've ever scraped your hand very shallowly, it can be very painful because what you've done is you've severed these little tiny free nerve endings, and it can be very, very painful. Also, if you put something like sanitizer or alcohol on there, it can hyperstimulate these nerves and cause a very painful stimulus. Okay. The Meissner's corpuscles, those are also superficial, okay, and they respond to light touch. So when you just press very, very gently on something, you are activating these mechanoreceptors. The Ruffini and the Pacinian corpuscles, these are type 2 cutaneous mechanoreceptors, and these are very, very fast reacting. And if you look at them, the Pacinian corpuscles are sort of in this mid layer, and they respond to pressure. So if you're pushing very hard on your finger, you're going to get activation of that Pacinian corpuscle. And so they actually react to an initiation and stopping a sensation, which is why they're so fast. The slow or the type 1 cutaneous mechanoreceptors, they take a long time to depolarize the nerve, and so that's why they're just slowly reacting. All of those receptors that we just talked about on the previous slide, they're what we call cutaneous receptors. So they're located in the skin, and they are not believed to be a major role player in proprioception. So for healthy individuals, you do not rely on your cutaneous receptors for proprioception. Okay, they pretty well stick to providing us information about the skin and about the environment on a very micro level. Okay. That being said, research has started to suggest that individuals who have deficient other proprioceptions, so for example, we depend on Golgi tendon organs, we depend on the joint receptors a lot for proprioception. So if you have altered sensation in your joint proprioceptors and your muscle proprioceptors, then your body will start to depend on things like cutaneous reception to make up for it. A prime example of an area where people lose proprioception is after an ankle inversion injury. So if you roll your ankle and you have injured your ATFL significantly, there are a lot of proprioceptors in the ankle joint and in that ligament specifically that you may damage. And so if you have damaged that ligament, oftentimes balance will be significantly impacted negatively, and the body may tend to rely more on cutaneous receptors. In that situation, those cutaneous receptors are hypervigilant and often respond very quickly as a painful stimulus. Muscle spindles are the most important mechanoreceptor for proprioception for joint position. Okay. So muscle spindles and Golgi tendon organs, these are attached essentially to our muscles and our tendons. Okay. Muscle spindles are within the belly of the muscle, whereas Golgi tendon organs exist within the tendon and at the musculotendinous junction. They sense tension within the tendon, and um, the Golgi tendon organ is actually responsible mostly for that deep tendon reflex, which we're going to discuss how that works in a couple of slides. Joint receptors are receptors that are found within connective tissues of the joint capsules. Okay, so within the joint, you're going to have certain types of receptors that will have different roles depending on what receptor is there. So Ruffini endings, these are located on the flexion side of the joint, and they're usually responsible for responding to sustained pressure or when a joint is hyperextended. Pacinian corpuscles, these are pressure and vibration receptors. We've talked about them already. The Golgi Mazzoni corpuscles, these sense compression within a joint. So they're usually they're usually located, let's go back to the chart. They're usually located within the joint capsule. They detect that joint compression, and a lot of times they're on the surfaces of the joint so that they can detect the compression accurately. If you would like more information on the different types of proprioceptors, there is an in-depth discussion about it within your textbook on chapter six, and you can also look at this chart for more information. Okay, so there are three different levels of response to proprioception. Okay, or we've got essentially three different hierarchical structures of how our body responds to proprioceptive information. Okay, you've got the spinal cord, you've got the brainstem, and then the cerebral cortex. So the spinal cord, that basically the proprioceptive information is controlled at the level of the spinal cord. It doesn't go up to the brain. At the brainstem, it ascends the spinal cord and it's maintained within the brainstem. And then the cerebral cortex obviously goes up the spinal cord, transitions through the brainstem, usually with some modulation at that point, and then it goes to the cerebral cortex. Okay, we're going to kind of chat about each of these. So the absolute fastest response is through the spinal cord reflex. When a tendon is stretched, so we're going to expand this image here. This is the spinal cord reflex. Surely you've been at the doctor's office when they've used a reflex hammer and tapped on your patellar tendon. Okay. What happens is you are rapidly stretching that tendon without a motor signal. Okay. So there's no motor signal to the muscle. By the hammer tapping, you cause a rapid stretch to that tendon. The Golgi tendon organ and the Golgi tendon organ and the muscle spindles are going to pick that up. And what they're going to do is they get confused. They're concerned that the muscle is being stretched beyond its means too fast. And so what they want to generate is a twitch response in reaction to that in order to protect the tendon. Okay. So the reflex hammer taps the tendon. The Golgi tendon organ picks that up as a stretch receptor. The yellow line here indicates the sensory nerve. So that sensory signal travels through the peripheral nervous system, through a peripheral nerve, It enters into the spinal cord through the dorsal root ganglion. Okay. Through the dorsal root ganglion, it synapses with an interneuron and with a motor neuron at the same level that it enters. So let's say it enters at the level of L5. So this is the spinal cord level of L5. At L5, it synapses with an interneuron and with the cell bodies of motor neurons. And so once it activates that motor neuron, that signal immediately goes back out to the periphery into the peripheral nervous system or to the nerve. And that motor signal or that motor neuron is attached to the quadriceps, and that's going to cause a contraction of the quadriceps to activate that muscle. Okay, so it's a protective mechanism. And this is why when you tap the tendon, you'll get this is technically an L5 reflex because this enters at the level of L5. You get a very, very fast sensory response down the sensory nerve. You get a synapse with the motor neuron, which fires right back to the muscle and it causes contraction of the quadriceps. It also causes contraction of the hamstring in order to allow for some co-contraction and some protection of that joint. I hope that makes sense. There are some great videos on YouTube that will describe that if you would like more information. The next level is the brain stem, okay? And this is the primary proprioreceptive center, okay? The spinal cord reflex, that is primarily for safety. It's a protective mechanism, and it has the fastest response time. The next fastest response time is the brain stem. And so, again, it's the primary proprioceptive center, and this is where information, a lot of times, it ascends the spinal cord, it meets interneurons, and it integrates with multiple other sources of information. Okay. The information will come from the periphery. It will be integrated with visual, vestibular, and other information from other body systems. And this is where, quote unquote, our balance comes from. So the cerebellum and the thalamus are a big part of integrating all the necessary information for responding to perturbations and movements. So it is the sort of next level up in terms of how long it takes. So it takes a little bit longer to get to the brain stem. It integrates information from the proprioception and from the visual and the vestibular systems, and the main effect is for balance. The highest level of cortical functioning is the cerebral cortex. Okay, this is the highest level of brain control that we have, and it's essentially conscious. So it's a center of what we call volitional control, or what's under your own volition. And so this is what we use to correct movement information before it gets acted upon. So if we are walking down the sidewalk and we kind of kick a little ledge, that's also going to elicit a spinal reflex, but we can sometimes override it through knowing that we're on a sidewalk and we're not in danger, and you'll just take a little bit of a step. Okay, so this requires conscious control. And again, your brain's going to integrate a lot of different information at that level. So that is cortical control of your balance and proprioception, whereas the brainstem and the spinal cord reflexes are subcortical. So they are not something you think about. Okay. If I had to sum up that whole rant, I apologize, in a few words, I would say the spinal cord reflexes, this is used as for protective mechanism, and it has the fastest response time. The brainstem, this is where a lot of information is integrated from proprioceptors, from visual, and from vestibular cues. Its main effect is on balance, and it's not as fast as the spinal cord reflexes. The cerebral cortex, this is the slowest response, and it is the highest level of brain control for us. It is the purposeful use of proprioceptive information. So motor patterns can be learned, and then it can become an automatic response through the cerebral cortex. this little character on the left here, which looks like it's out of a some sort of movie, but this is what we call a homunculus. Okay, the word homunculus in Latin means little man, and so what this indicates is this is what we call the sensory homunculus. So each body portion is representative of how much of the brain is dedicated to that area for sensation. Okay. And this is the same for the motor homunculus, which is a little bit different. Actually, I apologize. This is the motor homunculus because you can see the ears aren't as big. For the sensory homunculus, you've got very large ears. So, um, essentially, your brain, the motor areas of your brain, apply a large amount of the surface area and a large amount of the cortical area to the hands, to the mouth, to the face. Okay. If we look at the right, you can see we've got the primary somatosensory cortex, so for sensation. And on the left, you've got the primary motor cortex, okay, which is indicated in pink. You can now map out, if you were to take a cross section, if you cut the brain right like this, okay, and looked at it from a 90-degree angle, you would see, you wouldn't see these things, but you could actually map out where the sensation for the face is, where the sensation for the hand is located, the knee, the foot, all of the anatomical parts. This is very important for understanding where strokes may occur. If an individual has loss of sensory function in this area of their brain, it's going to affect certain aspects of their anatomy, right? As opposed to if the stroke occurred where maybe the representation of the foot is on the primary somatosensory cortex. So you can use that to make assumptions about it. We now use MRI and CT scans for those sorts of things, but it can also be helpful just from a clinical representation standpoint. Let's take a few minutes to talk about balance. Balance involves this close and intimate integration of three systems, essentially. We're looking at the visual system, the vestibular system, and the proprioceptive system. Okay. Proprioception we just discussed in detail. Okay, that's knowing where your joints are in space. The visual system, this is the information you get from your eyes, and the vestibular system, this is what you get from your inner ear. So this tells you the velocity, acceleration of your head, direction that you're moving, pitch, yaw, and roll, if you're familiar with those concepts. When your brain, okay, sorry, let me take a step back here. Proprioception is the most important sense for balance out of all three. Okay, your body relies on proprioception. Your body's relies second most on the vestibular system. So approximately 20% of balance is attributed to the vestibular system. And the last system is the visual system, which accounts for about 10% of your balance control. Now, if an individual is deficient in any one of those systems, obviously these percentages change. You become more reliant on proprioception or vestibular or visual if you have disruptions to the other systems. An interesting way to think about how the brain integrates this information is to use the example of car sickness. When your brain receives conflicting information from multiple systems, it has a hard time processing that, and it gives you some not so comfortable sensations. So this is where you can become dizzy, you can lose your balance, you can become nauseated, and you can even vomit if you're not getting the proper integration of this information. So let's take car sickness for example. If you're a passenger in a car and you're texting on your phone or you're reading a book, something of that nature, you may start to feel sick. Okay. The reason for that is you're reading a book, so your eyes are telling you that you're stationary, you're not moving at all. Okay, so that is 20% of the information to your body about where you are in space is saying you're not moving. Sorry, 10%. It's visual. Apologies. Your inner ear is telling you, because it picks up on this velocity and acceleration, your inner ear is telling you that you're actually moving at an incredible rate. Okay, especially if you're accelerating and decelerating, there are lots of stop signs and stop and goes. So your vestibular system is saying, whoa, 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 I'm moving. Oh, now I'm not moving. Oh, now I'm moving again. Now I'm going really fast. So these two systems are giving you conflicting information. Then you look at the proprioceptive system, and because of modern technology, cars don't have a ton of bounce and vibration to them anymore, but they do still have some. And so your proprioceptive system is feeling all these little bounces in the road, and your body has to sort of control yourself sitting upright against turns in the road. So your proprioceptive system is giving you even further different information. So if that's the case, then your body's going to get, you know, your brain's going to get a little bit confused, and it's going to start to give you uncomfortable uh, sensations like dizziness and nausea and whatnot. So that's how car sickness works. It's also how our balance control works, is integrating these three systems. A few tests that you should be aware of when evaluating balance. Um, you should be evaluating static balance and you should be evaluating dynamic balance. Okay. Static means not moving. Dynamic obviously means while moving. Static balance should be measured through the Romberg's test, the Stork test, and tandem stance. So, and I'll show you pictures of each of these in the next slide. But Romberg's test is essentially with your feet together, standing in position, looking straight forward. Okay. It's the most basic static test you can perform. And what you're looking for is the individual to maintain their balance for, say, 30 seconds without losing their balance or without a ton of sway. What you can do to challenge the balance system is have the person stand while staring at the wall. If they're able to perform that, then you have them close their eyes. Okay. And so this is going to impact the amount of visual information that they're getting for the proprioceptive system. Stork stance is when you actually stand on one foot. Okay, so it reduces the base of support and it increases the reliance on your proprioreceptive system on the one side. Okay. Tandem stance, on the other hand, is when you stand with one foot in front of the other, and you do this. You can do this with either foot in front of each other. And I would say, probably in terms of difficulty, it goes Romberg stance, Stork stance, then tandem stance. And you can do any of these with your eyes open and then eyes closed to further challenge the balance system. The left-hand side, we have Romberg's test. Okay, so just standing with feet together, looking straight forward. You can do this with the eyes open and then eyes closed. You're looking for them to hold it for about 30 seconds before you ask them to close their eyes. Tandem stance is in the middle here, and you can see one foot is in front of the other. This creates a much narrower base of support. It's actually quite a bit more challenging. And then stork stance is when you're standing just on one leg. These are tests. So you can, if you have a new client who comes to see you, you might want to measure baseline. So you can use a stopwatch and see how long they can stand. You can also make it more challenging by changing the floor that they're standing on, right? So you can make it more challenging by having them close their eyes or open their eyes. You can also tilt their head, so have them look upwards or look to the side to change the vestibular information. Or you can make basically their proprioception more challenging by having them stand on something that has a perturbation surface. Okay. Things that will help to challenge the proprioreceptive system are things like a balance disc, a rocker board. You can use a towel. You can use a pillow, which I have patients of mine use at home to work on their ankle proprioception. But these cause you to make continual adjustments to maintain balance. Okay, so they really stress those mechanoreceptors like the Golgi tendon organs, the muscle spindles, and these are excellent, excellent rehab tools. When evaluating dynamic balance, you're going to look at things like gait, so walking or running pattern. You can look at heel and toe walking. You can look at tandem walking. And you can do any of these with vestibular alterations. So vestibular alterations would be if, let's say, you're measuring their gait pattern and they can walk without issue, maybe you have them look to the right or to the left or look up. Or another one is have them with every step look the opposite direction. So look left, look right. And this integrates a cognitive aspect. This can be great for any sort of concussion rehab as well. Coordination is it's this it's this idea that you are it's primarily governed by the cerebellum and the thalamus, which again are significant relay centers between neural networks and within the brain. But coordination occurs when you move multiple limbs in tandem with each other to achieve um, coordinated patterns or patterns that are meant to move together. Okay. An example would be the eyes moving in tandem with each other. That's coordinated. That's a coordinated reflex that your eyes do in order to maintain gaze and in order to maintain a good focal point of vision. It's the complex process of smooth patterning between multiple muscles with incredibly accurate timing and activation intensity of the different muscles. Okay, so it's important for gross motor skills. It's also important for fine motor skills like handwriting, or I mean, video games. You have to have very coordinated efforts with your fingers. Um, and if you're going to improve coordination and if you're going to improve your performance of that coordination, repetition is very important. And this is because repetition will allow your cerebral cortex to learn that task. And then it might transition it from a task that's very cognitively challenging to something that you can perform without even thinking about it. So a perfect example would be typing on a computer, right? That's a very highly coordinated, fine motor task with your fingers. When you start to learn it, you have to learn the keyboard, which is a cognitive task, and then you also have to learn this highly complex coordinated motor pattern between your fingers. But now you are probably able to type a full essay and not even look at the computer while you're doing it because you've understood that coordination pattern and it's become an automatic response. The last thing I want to discuss is agility. Okay. Agility refers to the ability to control the direction of the body or limb during a fast movement. It's often the last aspect of rehab because a person needs to be able to move comfortably and safely before you can ask them to move fast. The old saying goes, you need to be able to walk before you can run. You need to be able to, for example, you need to be able to perform a movement very slowly and controlled before you can do it fast. Okay. You should always begin with basic rehab and then advance to more complex agility drills as the individual tolerates it. And in rehab, we typically start with simpler concepts and move towards more complex or more difficult. So start with strength and flexibility, usually some sort of stretching and strength routine. And then you want to incorporate balance. Uh, this you don't do balance first because there is a bit of an aspect of safety involved with it. So you want to make sure that the individual has the strength to balance before you can start putting them through balance tasks. Then you work on coordination and agility. Okay. Generally, we start with static activities and then move to dynamic. And highly complex dynamic activities usually are the buildup of less complex dynamic activities. Thank you for listening and tuning into today's webinar. I will post this as soon as I'm finished it, and I look forward to seeing you next week in class. And when I do see you, if anyone knows who this is, please raise your hand at the start of class and let me know. Have a great day, everybody.